Hi, I'm Dr. Nishant Yagnick. I'm faculty for neurosurgery for Marrow. And today we'll be doing the neurosurgery recall for the NEET paper, the neurosurgery related questions that have come in the recent paper in 2025. Let's go on ahead and see what they gave you as a surprise this time. So there was the recall of this particular question. Interestingly, the photo has also been recalled by one of the candidates, and the photo shows the skull of a child. You know it's the skull of a child from the fact that the face is actually much smaller than the head. The orbits are very large. The nose is really small. The jaw is very small, but the head is very large. So it's of a child, and the options given was that whether it's an image of the left plagiocephaly or right plagiocephaly. Now, plagiocephaly is a differential diagnosis for what is called craniosynostosis. I'm going to take this recall as if I'm hoping there are candidates who have no idea what what neurosurgery is. You might be preparing for some other topic, but it is relevant to you. So we'll start from with terms as if you don't know any of the terms. So plagiocephaly, craniosynostosis happens when the sutures, the cranial sutures, they don't have any gaps. They are fused. So if a cranial suture is fused, it doesn't allow the skull to expand with age, and that leads to a number of different head shapes. If, for example, the sagittal suture in the center is fused, it leads to scaphocephaly, which is like boat-shaped skull. So the skull grows anterior-posteriorly in front. You might go around the road and find, unfortunately, certain beggars, and you might even find people in your society who have this exact shape. It's rare, but you can see it in our country from time to time. And plagiocephaly is a differential diagnosis for craniosynostosis. Plagiocephaly is when there is, it's also called as positional flattening, where a child who is kept usually in the same position all the time develops an I wouldn't say abnormal. It's not considered an abnormality. It's considered a anomaly, an anomalous form of the shape of the skull, because the child sleeps always in one position. So, for example, in this child, there is a bulge of the right side, and there is a flattening of the left side. The answer of this question is left plagiocephaly, because plagiocephaly is flattening. The right side, which is bulged, is normal. So this is where the question is given, because in craniosynostosis, the part which is bulged is actually the abnormal part. If it's bulged from front to back, then it's because it's sagittal suture. If it's bulged from, for example, top, like a conical head, it's the metopic suture. So the bulge represents the abnormality, but in plagiocephaly, the flattening represents the abnormality. Now, it's a very interesting question to put for NEET, because it is a trick question, and unfortunately, those who don't understand craniosynostosis and plagiocephaly might not be able to guess it. So, I would strongly recommend the basic series of lectures in neurosurgery to understand these terms, and I've given all of these in slides and in photographs. So this is a GCS question, but again, they've tested your knowledge by giving you the GCS of a child. I do not expect actually people who have not prepared for neurosurgery to understand this, because GCS itself is hard to understand for candidates after their MS and preparing for MCH, and GCS of a child is actually very poor, is covered not so much. So, uh, following trauma, a baby was brought to casualty. The baby is opening eyes spontaneously. Spontaneous opening of eyes is automatically the highest score possible, right? Uh, there's an irritable cry, but the child is crying. Now, they have not mentioned how big the baby is, and there are scores meant for different kids. There are kids above 5 and the kids below 5, the toddlers, but they mentioned baby. So we're assuming it's around 6 months, 1 year, 1.5 years at max. Now, the child also withdraws all 4 limbs to pinch. So the GCS is actually 15 on 15. The GCS is full. You don't expect the child to answer your commands. You don't expect the child to localize to pain. The child will withdraw to pain. And the answer to this question is 15 on 15, because it is extremely hard to assess the GCS of a baby. And withdrawal to pinch is the max expected, especially in very, very young kids or neonates. So they will withdraw to pain. They will cry irritably because they've been brought outside their comfort zone. So they will cry. A crying child is more than enough. we don't go after criteria like babbling or single words, because that has to do with milestones. This is a very gross assessment of the child's consciousness level. So spontaneous opening, irritable cry, withdrawals all for limbs to pinch. My answer would be 15 on 15 GCS, highest GCS. Multiple hemangiomas. A clinical picture was given for multiple hemangiomas. I have taken these pictures from the web to represent whatever could have come. Remember, the VHL or is von Hippel-Lindau syndrome, and there are multiple hemangiomas that form in the entire body. It is generally studied in neurosurgery because the majority of hemangiomas actually form in the CNS, and it is over there that they produce the maximum symptoms. They don't form in majority in the CNS, but a small hemangioma, even multiple hemangiomas in the liver, will not be as dangerous or as symptomatic as hemangiomas in the brain or the spinal cord, which will immediately cause debilitating effects. So hemangiomas in the spinal cord are very commonly seen in VHL, not otherwise. Hemangiomas, interestingly, in the bones of the spine, the spinal bones, vertebral bodies, are actually fairly common even in patients who don't have VHL. But if they're forming in the soft tissue of the brain, and especially if they're multiple, there are various criteria for VHL diagnosis. But multiple hemangiomas is essentially the clinical the picture of the clinical diagnosis. And here you can see hemangioma formations in the liver. You can see them in the brain here and here. You can even see them in the spinal cord. And this is a diagram which shows where all they can form. So areas of increased risk of non-cancerous tumors are cerebellum, the eyes. They can form inside the eyes. They can form in the spinal cord, and they can be cancerous hemangiomas or hemangioblastomas, and that can form in the adrenal glands, the pancreas, and kidneys. So the question can come from both sides, neuro and non-neuro sides. So there was an image given with posterior fossa complex pilocytic astrocytoma. I don't know what a complex pilocytic astrocytoma is. It's a pilocytic astrocytoma, and an image of hydrocephalus and an image of a posterior fossa hematoma. Now, I don't know what the question was exactly, but I have given images of which are representations of all three. It might be a spotter to differentiate between posterior fossa hematoma and posterior fossa pilocytic astrocytoma. So this image represents the pilocytic astrocytoma. When we mean posterior fossa, we mean cerebellum and the contents under the tentorium cerebelli, which is the back on lower, the inferior posterior part of the brain. It has the brainstem, it has the cerebellum, it has and it continues down into the spinal cord. And the most common tumor in children of grade 1 is pilocytic astrocytoma. It generally occurs in kids, and it has a very classical appearance of a cystic tumor with an enhancing central component called a mural nodule. Another tumor that presents just like this are called hemangioblastomas, and they occur more in the adults and not children. Pilocytic astrocytomas are some of the few rare grade 1 gliomas, which means that if you remove the mural nodule, the tumor often doesn't come back lifelong. It is one of the only few curable gliomas. And this is the picture of a pilocytic astrocytoma. You can see that there is a cyst-like cavity. This hypodense fluid is similar to the CSF, so it's all fluid. And in the center, there is an enhancing nodular structure, and it's a mural nodules. And this is a picture of a pilocytic astrocytoma. We just call it piloastro. And here you can see a hematoma. So again, posterior fossa. In fact, it's a hematoma of the cerebellum, which is compressing the brainstem here, which is totally edematous, almost infarcted. The sagittal picture of the same, you can see a bleed here with the compression of the brainstem. And this is a picture of hydrocephalus. So hydrocephalus pictures can vary depending on what level they have given of the section that they've given of the brain. This is a midsection where the ventricles of lateral ventricles are seen, third ventricle is seen, and in the center, and the posterior horns are seen. This is a cut in the superior to this, where you can only see the lateral ventricles and the septum dividing them. So this interventricular septum. So what you see here is the fact that these ventricles are enlarged. Also, you can see these representations. Even here, you can see that this grayish here, and here also it's grayish. This is called periventricular lucency, which means that it is a severe hydrocephalus which is producing pressure on the brain because the fluid is forced to come out into the brain through a transependymal route, indicating that the brain is under severe pressure and causing brainstem compression, requiring diversion. So I've given images of all the three options. I don't know what the question was. It might have been a differentiation between piloastro or posterior fossa hematoma. Maybe it's just one image, and these are the recollections of what it might have been from the candidates who have posted the questions for us. Again, very surprising. You don't expect them to give spotters like these in a more generalized paper that is NEET, because it requires you to cover the entire basic lecture series that we have to be able to even have any clue of guessing these spotters. It is radiology, it is neuroradiology that you need to know. So they really expect you to go deep into your topic. That's interesting. Again, a question on cerebral microdialysis. Now, this can be labeled as a question on trauma as well, because it's generally used for understanding raised intracranial pressure in head injury. Cerebral microdialysis is a technique where they place a catheter inside the brain. Just like in dialysis, a dialysis type fluid, infusate, is placed in the locoregional area of that particular part of the brain, and it, through a diffusion principle, it helps to measure the various chemicals present in the brain, such as lactate, pyruvate, and these chemicals show how bad the injury is and help direct treatment. So when they say direct treatment, it means does the patient require increased oxygenation, ventilation, maybe electrolyte changes, maybe increased decongestion through 3% normal saline or mannitol. Again, I have never seen cerebral microdialysis. It is not discussed in the majority of forums world over in trauma. It is rarely ever done. It still has a more research-based role than a practical role, because a lot of our decisions for surgery are actually based on the patient's clinical condition and the radiological picture. So but it is considered an important question when we discuss how ICP is measured and what are the methods to understand intracranial pressure, especially in head injury. So it is essentially a theoretical question. So the question was about which statement is false. It is invasive. Yes, it is invasive. That's not false. It is a biochemical test based on diffusion principle. Yes, it is a biochemical test based on the diffusion principle. I don't know what the other two options was. One of them would have obviously been false, but these two options have been submitted by our candidates in their recall. So this comes under the ways to study raised intracranial pressure. The other ways are also ICP monitoring through, for example, intraparenchymal, subdural, and intraventricular catheters, both based on water-based mechanics, hydromechanics, or electrical transducers. There is angiography that is utilized to understand the blood flow to the brain in raised intracranial pressure. So right now, even in my hospital, we use intracranial pressure monitors directly. So that is the usual state of the art thing that we do. But you should know all of these techniques apparently for your NEET exam, so you can score well in neurosurgery. Now, they have asked you a question apparently on basilar invagination and platybasia. No one who has not done a core study of neurosurgery is ever going to be able to answer this question. It's not a matter of whether it's been asked before. These are very closely related conditions. Basilar invagination is when the odontoid process of the C2 vertebra, I can't make this simpler, you have to just know it, is seen to go superiorly to the Macrae's line. The Macrae's line, as represented maybe by, if I draw a line from here to here, is the line from the base of the clivus to the posterior border of the foramen magnum. So this is the Macrae's line. The odontoid process should be under the Macrae's line. If it is above the Macrae's line beyond a certain point, it changes with respiration, by the way. Beyond a certain point, it is considered a basilar invagination, which means that the neck is short and it is related to a condition called atlantoaxial dislocation. This is a complex topic. So in this condition, you can see that the Macrae's line is actually ending here, and this is the Macrae's line now. Because this is called platybasia. And platybasia is when the base of skull here, the base of skull is of a certain is at a certain beyond a certain degree. I think 153 degrees was the answer, but I'll have to recheck that. And if that happens, it's called platybasia, where the base of skull is essentially flat. It is supposed to be rounded and curved, but it's not. It's flat. So this is a picture of platybasia with basilar invagination, where it is these two things are commonly occur very commonly together. This is the condition of platybasia, because here it is. Here there is the kya bolte hain, Here there is a flattening of the same basal skull, but without basilar invagination. So it can occur with basilar invagination, it can occur without basilar invagination. It is not hard to recognize basilar invagination. It is not that hard to recognize platybasia either. So, but you need to know what these are, and you need to know what the images look like. This is the classical image that I would think they must have placed, where there is a significant brainstem compression. There is also tonsillar herniation here. The base of skull is completely flat, and the odontoid process is going significantly through the Macrae's line. So this is basal invagination with platybasia, and they've given you a spotter like this. Then it's tough luck for those who have not read any neurosurgery. Pituitary macroenoma is above 10 millimeters. I don't know what the options was, but basically there must have been an easier question on what is a microadenoma, what is a macroadenoma. Macroadenoma is above 10 millimeters or 1 centimeter. Micro is under 10 millimeters. Not much discussion there. You just need to know this. Okay, what is Brown-Séquard syndrome due to? So Brown-Séquard syndrome is hemitransection of the spinal cord. You've read this also in your first year physiology. It is a very commonly studied syndrome to understand the tracks that are moving in the spinal cord. What are the descending tracks? What are the ascending tracks? What are lateral tracks? What are the medial tracks? And it is experiments with hemisection of the spinal cord where we understood what tracks move where. In clinical practice, you will rarely get a Brown-Séquard syndrome. Brown-Séquard syndrome actually occurs in thrombosis of the anterior spinal artery or any other artery that is supplying, or the branches of anterior spinal artery that is supplying one side of the spinal cord. And because most of the conditions that affect the spinal cord rarely would do a hemitransection, they would just blow up the spinal cord completely. Central cord syndrome, as opposed to hemispinal syndrome, is much, much more common because it is commonly seen in cervical spine injury. But Brown-Séquard syndrome is quite rare. Now, because it is a hemitransection of the spinal cord, it is easy to understand that it is an intramedullary thing. When we say intramedullary, we mean something within the spinal cord. Extramedullary is outside the spinal cord. Intradural is within the dural covering of the spinal cord, but outside the spinal cord. And extradural is outside the dural covering. So there is a spinal cord, there is a dural covering like a layer of tarpaulin, and then there is the outside space. What is within the spinal cord is intramedullary. What is between the spinal cord and the outside dural covering, which is a thick, like sheet-like layer, thick sheet, is extramedullary but intradural. So it's called intradural extramedullary. The commonly used abbreviation is IDEM. When we do tumors, we say, what tumor was it? It was an IDEM, which means it was most likely a meningioma or a schwannoma with intradural extramedullary location. Intramedullary tumors are ependymomas, astrocytomas. They occur within the spinal cord. And extradural tumors are usually bony tumors, but the most common case you'll get of extradural compression is going to be the most common case you will do in neurosurgery electively. It will be a intravertebral disc. So prolapsed intervertebral disc is essentially compressing the spinal cord extradurally. So extradural means what is outside the dura. There is nothing like extradural intramedullary. It makes no sense. It doesn't exist as an entity. Intramedullary are tumors and Brown-Séquard syndrome. Extradural are usually extradural tumors or most commonly prolapsed intervertebral discs. Syringomyelia is a condition where there is a blockage of the central canal of the spinal cord, which contains fluid. And this causes a very specific syndrome, including a very interesting condition, very common asked MCQ question called suspended anesthesia, including crossed anesthesia. So suspended anesthesia is where you have anesthesia in a certain part of the body. Above it is normal, below it is normal. So it's like the anesthesia is suspended in between. And the localization for this, there is a syringomyelia. So the answer for this question would be intramedullary. Blood-brain barrier is present in very, very weird question. Okay, very weird, especially with these choices. So blood-brain barrier is present essentially in all the intraparenchymal tissue. It is actually a barrier at the capillary level of the blood circulation of the brain. It occurs in the entire brain. So does it exist in the choroid plexus of the third ventricle? Not really, because choroid plexus of the third ventricle is essentially just a bunch of blood vessels. They have their own barriers that helps produce CSF. But it's not exactly a blood-brain barrier. It's a blood-CSF barrier. Floor of the fourth ventricle, again, when they mean that, there is a choroid plexus there as well. And I'm not sure whether they mean floor of the ventricle itself, because it's an ependymal layer. the ependyma or covering. We just mentioned in hydrocephalus there'll be a transependymal flow. So the ependyma is not the blood-brain barrier itself. It's not in the parenchyma. It's a separate epithelium, form of ependymal epithelium. So then comes neurohypophysis and anterior pituitary. So anterior pituitary is not exactly a direct representation of the brain. It is considered, yes, but it has a lot of other cells that produce hormones. We know this. The neurohypophysis, the posterior pituitary, is actually the direct descent of the brain into the posterior into the pituitary fossa. And we know that there are nerve endings here that produce vasopressin and other hormones of the neurohypophysis. So definitely because of this, it is brain matter. And therefore, my answer would be blood-brain barrier is present in the neurohypophysis. Now, if I've searched this online, but there is no actual answer to this question in the same exact way. It is the answer should be based on what is representing brain parenchyma and what is not. So neurohypophysis actually represents actual cranial nerve cells. Anterior pituitary is more filled with separate types of cells that produce hormone generating hormones. And it also has a portal circulation, a pituitary portal circulation, just like any portal circulation where hormone release occurs. And the floor of the fourth ventricle, of course, is formed of the ependyma, which is not exactly a blood-brain barrier, and choroid plexus is also not a blood-brain barrier; it's a blood CSF barrier. So, my answer would be neurohypophysis. Again, not a question I would expect for a NEET exam. So there were images given, and they were asked what is false. This, I think, the question itself is wrong because I have researched this through and through before this presentation. Uh, Sometimes we get the questions on the basis of the recall, so it's difficult to actually. Maybe there's a fault from the person who's recalled it. They've not recalled it exactly, but some image was given and it was decided which is false has to be mentioned. Now, if they've given a fawn tail is basically a tuft of hair on the lower back of a baby. It is an occult sign for spinal dystrophism. There could be spinal dystrophism under it, there might not be, but most of the time there is spinal dystrophism. When we mention spinal dystrophism, please understand it is a very broad term that represents abnormal embryological development of the neural structures. And when you say spinal dystrophism, you mean of the spinal neural structures. And it includes a whole lot of conditions. There are lipomeningomyeloses, there are myeloses, there are meningomyeloses, there's open spina bifida, there is diastomatomyelia, there's diplomyelia. So, there's tethered cord, also. So, I have gone through heaven and hell to find out the types of spinal dystrophism. And there are multiple papers on types of spinal dystrophism, but they're only related only recently in a single paper on the types of lipoma in spinal dystrophism when there is a lipomatous tethered cord or meningomyelocele. No one has clearly mentioned any type 1 spinal dystrophism, type 3 spinal dystrophism. So they mentioned in terms of lipoma, which is new research, which we do not expect in a exam. There are definite two types of spinal dystrophism in split cord malformations. Diastomatomyelia is type 1, diplomyelia is type 2. Please refer to the lecture series for understanding both. It's a very large topic. Occult spinal dystrophism is when there is no cover. So when there is a cover and you don't know that exists because outside there might be a fat layer and there is no indication that the patient has spinal dystrophism. Fawn tail is when there is an indication of spinal dystrophism. So most likely they must have given an image of a fawn tail, some hair or some dimple or some sinus or some lipoma in the lower back, and it's just called a occult spinal dystrophism. And if they're given a fawn tail, which is hair, then maybe it's a fawn tail. So this is a very classic thing. You can find it online. But type 1 and type 3 spinal dystrophism is I think it's just a misleading thing. There is type 1 ulnar cherry malformation, there's type 2, type 3, type 4. 1 and 2 spinal split cord malformations. There is type 4 types of, now in one research paper, there is, which I don't think this published in a textbook yet, 4 types of lipoma based, embryologically based lipomas in spinal dystrophism at the end of the cord. So I don't know what they mean exactly by type 1 spinal dystrophism because it is a condition that encompasses so many conditions that have their own types. So I don't think this is the right choice. What they must have done is just given you an occult spina bifida or a fawn tail, and that must have been the answer. So with that, we've covered the questions. Again, my thoughts on this are, as a faculty, and after a good number of years of experience now, seeing these papers, this was a tough paper from neurosurgery side for NEET. These are questions you expect in INI, NEET SS, that you would definitely expect there. Even there, it would have caused a significant amount of confusion. So, if you really want to prepare, the answer is you at least need to go through all for NEET. You need to go through all the lectures of all the topics. Um, at least listen to them once or twice. You might pick up a few answers. Just the images in the lectures given will help you answer a lot of questions. There's a lot of spotters this time from neurosurgery, including neuroradiology, something you don't really expect in a generalized paper of NEET. Still, I think these are the questions that decide who are going to be the toppers and who are not going to be the toppers. Remember, if they're tough for you, they're tough for everyone. So if you get even one or two questions right or three questions right among these 11 questions that came from neurosurgery, believe me, it will put you far ahead of the others because the rest of them will not even attempt it. The aim at least is to remove two options and take a chance on the other two. So with that, hopefully you guys did very well, and hopefully the future generations will also do very well. Best of luck for your paper. Thank you.